We're very fortunate to have this incredible panel of NET experts join us from across the country today. All of our speakers are deeply committed to the NET community and are active in national NET organizations, NET research, and of course, they see and treat NET patients as well. So it's an honor for me to introduce again our speakers for today. Dr. Heloisa Suarez, medical oncologist from Hudson Cancer Institute, Dr. Kalicia Clark, surgical oncologist from Medical College of Wisconsin, Dr. Thor Hofdunarson, medical oncologist from the Mayo Clinic, Dr. Thomas Hope, radiologist and nuclear medicine physician from UC San Francisco, Dr. Charles Nutting from the Endovascular Consultants of Colorado, Dr. Heidi Del Riviero, endocrinologist and medical oncologist from the NIH, and Dr. Pamela Kuntz, medical oncologist from the Yale Cancer Center, as well as Josh Mailman, president of NorCal CarciNet and patient advocate extraordinaire. Josh will be serving as co-moderator for today's Q&A. And let's start with the first question. And this question will be for you, Dr. Hofdunarson. Describe NET cancer frequency compared to breast, 1 in 8. Review NET cancer incidence, prevalence, and translate this from X in 100,000 to 1 in question. So Dr. Hofdunarson, take it away.
I will try to do my best. I am not really good at math, so I will warn you. So just to give you an idea about the comparison between breast cancer and neuroendocrine tumors. So in the US, you're obviously looking at, in terms of breast cancer, overwhelmingly female population, but we're looking at almost 300,000 new cases of breast cancer among women in the US per year. We're looking at 23,000 new neuroendocrine tumor cases across the US over a year. So you see that, and that's both for men and women. So you see that there is a vast difference there. If we put it into a perspective, and for me, I sometimes explain this, living in Rochester, Minnesota, which is a town of about 100,000 people, that equals about 7 new cases in Rochester per year of all neuroendocrine tumors of all origins and grades. So it's not very common, but it's not very rare either. So, but just because many patients with NETs live for a long time, the prevalence, so the number of people actually living at any given time with the disease is actually very high. So it's we add relatively few new patients to the pool every year, but there's a lot of people with active NETs out there at any given time because thankfully survival is very favorable compared to other cancers. So hopefully that explained it, and I can go into some more details.
Okay. If not, then moving on to another question about causes, which is very common and, of course, understandably a concern for the NET patient community. Does chronic stress cause cancer? And let's ask Dr. Suarez if you might address this.
That's a very interesting question. I don't think we have clear documentation because a study like that will be very hard to do. But at the same time, there have been studies done, particularly I think in mice, that show that animals that have been on continuous stress had developed alterations in their systems that led to several illnesses, including potentially cancer in the mice. So right now in humans, we don't have that confirmation. But I think someone that lives on years of stress because of potentially all the hormones, that could be something that might develop in the future. Again, this is completely just my thought, and I would love to hear from my colleagues. And we don't have any clinical trials to validate that.
Dr. Hofdunarson, Kuntz, or Dr. Clark, if you have anything else to add?
You know, I get that question a lot as well, and I try to deflect a little bit, and because we really don't know that it causes cancers, but we do have at least some anecdotal evidence that it affects the way that people sometimes respond to treatments and respond to surgery. So we spend a lot of time sort of focusing on stressors that we can try to control or minimize. Especially, I'm particularly interested in that period between diagnosis and surgery. So in cases where we're doing a neoadjuvant approach, where patients have the anxiety of waiting for the surgery and they think surgery is a big moment. I think stress during that period can certainly impact the way that you respond to treatments, but also how you recover from surgery. So we actually try to integrate a clinical psychologist that's able to help minimize stressors with behavioral changes, focus on small things that are actually seemingly big things like insomnia, anxiety, especially during that neoadjuvant treatment and the immediate postoperative treatment, because I definitely think that there's a link there.
Thank you for that. And that's really encouraging to hear that, yeah, even, from a surgical standpoint, you're thinking of the whole person and the whole health. Thank you. Dr. Kuntz, there's a timely question that came up, of course, about COVID. It's not surprising. Neuroendocrine cancer and COVID, I'm sure you get this a lot. Are we at greater morbidity risk? And is there any consideration for therapies and vaccination timing?
That's a great question. And yes, timely. I mean, I think that broadly, we know that patients with cancer do have increased risk for serious outcomes from COVID. I think that there's probably a huge range depending on whether patients are on treatment, have recently had a big surgery, where they are in the course of their journey. So I think there are a lot of caveats to that. And there have not been large studies looking at patients with neuroendocrine tumors. I get asked frequently also about the safety of the COVID vaccine and the efficacy of the COVID vaccine in the NET patient population. And I think that broadly, our American Society of Clinical Oncology has come out with a statement saying that patients with cancer should definitely get the COVID vaccine. We think that it's effective. There are specific patient populations that it may be less effective, and those are patients going through bone marrow transplants and patients who are receiving a very specific type of immunotherapy called CAR T cells. I'd welcome other input from my co-panelists.
Dr. Halfdanison or Suarez?
So I can speak to it a little bit. So we are just about to publish a large international registry on neuroendocrine tumor patients with COVID. So sort of joining forces with investigators in Italy and Spain. And there is definitely increased mortality, but not as high as seen in the early studies of cancer patients in general. With COVID, probably to some extent reflecting that many of the neuroendocrine tumor patients are not on very aggressive immunosuppressive therapy. But otherwise, I have not much to add to what Dr. Kuntz said.
Thank you for that.
We do try to separate the administration of the COVID vaccine from surgery. Surgery in itself can sometimes be somewhat of an immunosuppressant state. And we do have evidence for prior vaccinations that delaying the initial inoculation from surgery a few weeks can actually potentially increase the immune response. So right now at our institution, we try to wait 3 to 4 weeks after major abdominal surgery to then administer the first dose of the vaccine.
Thank you. And that's helpful to know because as you know, patients are still undergoing surgery at this time. I know, Dr. Clark, you mentioned in your talk about some morbidity, and there was a recent paper that came out, and I'm going to direct this first at Dr. Halfdanison, because I saw you tweet about Dr. Hallett's paper that was recently published. If you might comment on, well, the question is, could the presenter summarize the recent paper that was published by the authors in Toronto about specific prognosis? And if you might comment on what that paper was and give a little summary.
So I can, as I brought this onto myself by tweeting. So this is a really nice study that's coming out in one of the scientific journals, looking at the prognosis or life expectancy of patients with neuroendocrine tumors using a very large Canadian data set of about almost 10,000 patients. And what they found is that in patients with metastatic neuroendocrine tumors, they are certainly at much higher risk of dying of metastatic disease than from other things. But on the other side, the patients with the stomach, colon, rectal, and I believe pancreatic neuroendocrine tumors, if diagnosed with localized disease and if they had appropriate surgery, their risk of dying of other causes than neuroendocrine tumors is actually higher than dying of recurrent neuroendocrine tumors. And I will say that this is in line with a similar study that we just actually published this year using a US data set of almost 100,000 patients, but we didn't go into all the same details as the Canadian team did. So what I'm saying here is that for early stage resected, low grade, grade 1, grade 2 neuroendocrine tumors, the long-term prognosis is actually very, very good.
Thank you for that. And just for the sake of time, because we have so many more questions, I'm going to move along to workup and some of the workup that's required for this disease. And Dr. Suarez, let's go to you. Do you recommend EGD and colonoscopy for all initial NET workups?
Not necessarily. If I have good imaging that already tells me where the primary tumor probably is, for managing the patient, I will not necessarily do it, especially if we feel that's in the small bowel. Chances are that we're not going to reach the small bowel. So I will say probably in my practice, the minority of the patients I'll have to recommend it, just because we're doing so much better in terms of imaging. Having said that, I think in general, particularly for patients that are young and overall are healthy, where we feel that these patients will do well for very, very many years to come, I think they should continue to have all the appropriate screenings for their age, just plugging this extra additional information there.
I just wanted to echo what Dr. Suarez says. I probably diagnose at least 2 colon cancers a year from just recommending screening colonoscopies in patients that are seeing me for a completely different cancer type. And most recently, this was actually a neuroendocrine patient of mine that had a small bowel neuroendocrine tumor. And I remember she was so upset with me because she just wanted to have surgery. And I thought, you know what, we really need to get this colonoscopy. And we did find a transverse colon cancer that would not have been resected in her surgical specimen and would have been left behind had we not known that going in. So we just saw each other last week, and she joked about her free surgery, because it sort of was. It was something that we would not have been able to predict, and eventually perhaps we would have found that tumor, but again, it would have been a second surgery, more morbidity, and potentially more advanced disease at the time of presentation. So I do agree that I encourage patients that are seeing me, if they have not undergone their routine screenings, especially for colonoscopy and colon cancer, I do recommend that. But outside of that, if I have good imaging about the location, I don't typically recommend it.
Thank you for that. That's very helpful. Dr. Kuhn, let's start with you with this question. Please speak to NETs with unknown origin. I'm sure you get this a lot also. How does not knowing the origin of the well-defined grade 1 metastatic NETs affect diagnosis, treatment, and survivability?
Happy to address that. First of all, I think that that's becoming less and less common now with our better imaging. And I think especially with our somatostatin receptor-based imaging, like Gallium-68 DOTA-PET or copper-64, I think we're having better luck finding the primary tumors than previously. But this is still a clinical challenge when this does in fact happen. We still have therapies that we can offer to these patients that we think may be applicable to a number of different NET primary sites. Somatostatin analogs, everolimus, ludotate, these are examples. But I will say that our clinical trials, as I spoke to in my talk, are really nowadays being directed at studying specific primary sites. And so it does help us tailor the treatment if we know the primary site in advance. So I had one more thought, and maybe I'll actually ask Dr. Clark. Knowing the primary site is actually really helpful as we think about some surgical planning. I'd say especially for small bowel NETs. I wondered if Dr. Clark could speak to that.
So absolutely. I think this issue has gotten a lot simpler with better imaging. And so very, very rarely now do we actually operate without having a fairly good idea about where the primary tumor is. In the setting of small bowel neuroendocrine tumors, however, these primaries can be so small, it's often missed on cross-sectional imaging. And one of the frustrating things is sometimes that ends up resulting in a significant delay in sort of surgical treatment. And I'll tell you that if you can see a lymph node within the mesentery, that it's almost always going to be a small bowel met. And rather than trying to get additional imaging or capsule endoscopies, et cetera, I think the place that those patients really need to be is in the operating room, because we can almost always find those primary tumors on palpation or direct examination of the bowel. It doesn't even mandate an open operation. We can still do this laparoscopically with either a small incision for a hand port to basically manipulate the entire bowel. But if you can see a large lymph node in the mesentery, we can almost always find that primary tumor.
Mm-hmm. Thank you for that. And speaking of, getting in there and finding the tumor and taking a look at that, Dr. Suarez, I was wondering, there's a simple question about how do you get the tissue to test for the Ki-67?
That will be a biopsy that can be, if we have a surgical path, obviously, if the surgery, the tumor was removed, then the pathologist will slice the tumor and then use a special staining to look for that and grade how many of the cells are positive for that in regards to the rest. And then if you don't have a full sample of the tumor, just a biopsy of let's say a metastatic side of the primary the pathology can do the same. I have to say, and I would love to pick my colleagues' brain on that, there is a lot of variability within the tumor, what's the Ki-67. And I don't know how much you discuss that with your patients, particularly if you have a sample or you have a large tumor and you have different Ki-67s that were done, and then the patient asks you. So, but yeah, you calculate that using the tissue that you have.
Dr. Halfdanison, Kuntz, or Dr. Clark, do you have anything else to add to this?
So I would echo what Dr. Suarez said about the what we call the heterogeneity of the Ki-67 within the tumor. So keep in mind, we're only testing a minuscule sample of the tumor, so that does not necessarily reflect the entire tumor. So what I tend to do, I have a low threshold for repeating a biopsy. Let's say if there is a liver lesion that's growing out of sync with some of the other lesions, especially for pancreatic neurotumors. I've been surprised so many times with what I call sort of a grade, tumor grade sliding or tumor grade shifting into a grade 3 that may actually call for different methods for treating.
And I'll just say we're actually publishing this paper right now. I think it's under review, but the accuracy of FNA Ki-67 estimation within the same lesion is actually really good, at least at our institution. And I think that the caveat is that we have a pathologist who's present at the time of the FNA biopsy, and they sort of determine adequacy of the tissue sample. And so along with the technician that's performing the biopsy. But at our institution, the accuracy of grading tumors was very high. And where we ran into difficulties were more in the grade 2 tumors that were at the lower end of the spectrum for Ki-67. So differentiating between a Ki-67 of 2 versus 5. So those were most of the errors actually occurred. So it really is, if we're unable to have a surgical specimen, I do counsel patients that the FNA biopsy gives us some really important information. And in most cases, it's accurate. In some cases, it's not. But it certainly is, it's not a wild guess at all.
Thank you for that. That's really helpful. And we look forward to seeing that paper. Let's ask Dr. Halfdanison, if a primary is found to arise from a rare location like a tail gut cyst or epidermis cyst, can it still cause the same disease as a PNET?
So so these tumors, they can metastasize, and they, for example, if you're looking at that specific example of a tail gut cyst, which are rare neuroendocrine tumors and can be associated with a rare syndrome called Currarino syndrome, and they can metastasize. They can have carcinoid syndrome with production of serotonin. They rarely do produce any other hormones, but essentially they can. They are similar in the way that they can metastasize. They seem to have the same ability to metastasize as do other neuroendocrine tumors. But in terms of functional tumors, they may or may not be functional. Probably most often non-functional.
Thank you for that. Let's take a couple questions about biomarkers. And I know this is a big topic. Dr. Kuntz, with consistent elevated multiple high chromogranulin A and clear symptoms, why is it so difficult sometimes to find a recurrent NET?
That's a great question, and certainly something we all face clinically in patients. And I think that, the first comment I'll make is that many of our existing tumor markers are imperfect. And chromogranin A is definitely one of those. And I think that elevated chromogranin A in someone who previously had a resected NET that we thought had, a curative intent surgery and was removed. And elevated chromogranin A does not necessarily indicate recurrence. I think that an elevated chromogranin A can be elevated for other reasons. Certainly, it can fluctuate quite a bit in individual patients. And I think the community, and there is an ongoing study looking at this. I think Thor still has it open at Mayo, looking at chromogranin A and trying to validate that a little bit more, and seeing if it really tracks with scans. But it's, I think the pendulum has swung away from using that. I'd like to just also define for our listeners the difference between a tumor marker and a hormone marker. So tumor markers are ones that would not necessarily be linked with symptoms like carcinoid syndrome. So a tumor marker is really more like PSA for prostate cancer or a CEA for colon cancer. That in an ideal world, that marker would increase at time of recurrence or tumor progression and decrease at the time there's tumor response. The hormone markers are something completely different and can be very accurate for individual patients. So for patients with a pancreatic NET that maybe have insulin secretion or vasointestinal polypeptide, we do follow those regularly.
And let's go to you, Dr. Halfdanison, with this question, if you might speak on the accuracy of the NET test for monitoring and surveillance purposes.
Sure. So NET test, as you may know, is one of the more recent tumor markers, and it's different than most of the others as it relies on sort of genetic signature detected in the blood, usually what's called transcriptomic analysis. So it is a very interesting test. So we know it's definitely outperforms chromogranin pretty much in all studies done. But then, as Dr. Kuhn said, chromogranin is not a good marker, so outperforming chromogranin doesn't necessarily mean that a test is good. And it's just better than what it was compared to. But that said, it seems to be more sensitive than any of the other markers around. And it seems to have like a version of it seems to have a predictive value in terms of patients undergoing PRRT. And that's very, very intriguing to me. We might be able to predict how people do after PRRT. And then recently, there was an interesting paper in one of the surgical journals on looking at NET tests following resection. And I've started to use it a little bit in patients who've had complete resection, doing a NET test a few months after the operation. And based on the results, whether it's a high or low or somewhere in between, I might decide on when to do the next scan, be it 6 months or 12 months after that surgery. I will say that is, I don't think it's really validated for that use yet, but it seems like a test that performs well. I think there is a lot more work to be done with a NET test. Ideally, we need to build this into future clinical trials. So where we do trials very rigorously, we should put the test to the same rigorous methodology as we do drugs. And I hope and I think that's going to happen soon.
Thank you for saying that. I also think we need to validate that in the constant context of clinical trials. And hopefully, by the end of the year, we'll have an adjuvant study to look into capecitabine and temozolomide in patients that we believe have high-risk features for recurrence of the resected pancreatic neuroendocrine tumors. And we are incorporated in the follow-up the use of the NET test after the resection to see what we capture at 6 months, and then in 3 years or at the time of recurrence. And hopefully that will continue to support and validate the use of the NET test. So thank you for bringing that up.
That is excellent news. I'm very glad.
Yes, that is excellent. And speaking of resection and such, I'm going to transition to some surgery questions, so we make sure we make time for that, since there has been several that came in. Dr. Clark, would you address this question about what is a primary cause of intestinal blockage in NETs patients, and what's the usual treatment for a blockage?
So it's a sort of a complicated question. So it could be from a variety of things. So it could be from the primary tumor. The primary tumors are very small, but they sort of have what we call a desmoplastic reaction, where they sort of pull tissue into the lesion. And so it is easy for the bowel to get sort of folded on itself around a very, very small, like 1 centimeter tumor. More commonly, what we see, though, is obstruction from lymph node metastases, lymph nodes that are actually in the mesentery of a bowel, which is sort of a curtain that the bowel is attached to. And again, these tumors try to grab on to tissue that lay adjacent to them. And so it's very easy, again, for the bowel to be kinked or sort of brought into this lymph node metastasis. And then also, it could also be from just peritoneal metastases. So these are cancer cells that are outside of the lymph node, outside of the primary. This would be technically stage 4 disease that can, again, cause the bowel to get kinked off or occluded from tumor growth. And so in these patients, especially for patients that have low-grade disease, surgery is a very good option, if possible, to alleviate obstruction. And I tend to be fairly aggressive about that. In the setting of having high-volume disease that's not necessarily amenable to surgical resection. So, for example, if we have one large lymph node that's really pulled in a lot of bowel and we're worried about leaving somebody with functional shortgut, we also sometimes have the option of doing bypass surgery where we don't actually take out the blockage, but we create a new point of transit for things to move through the bowel. So there are a lot of surgical options. Obviously, these decisions are always made in conjunction with my entire team in a multidisciplinary fashion. So my medical oncologists are also very critical in the decision making in terms of who goes to surgery or not. But I do think that surgery has the best long-term result in terms of trying to relieve those obstructions.
Thank you for that. And another question that came up is, Dr. Clark, is a radical resection recommended of all diseased inguinal lymph nodes under 2 centimeters in size, knowing lymphedema happens and lymph bypass surgery is available?
Okay, so this is in the setting of known lymph node metastasis in an inguinal basin. Yeah, so we do recommend completion lymph node dissections for metastatic neuroendocrine tumor to a lymph node basin. It's a fairly rare setting. We typically will see that in the setting of either rectal primaries or sometimes from neuroendocrine dermal tumors like Merkel cell carcinomas, et cetera. And the reason we recommend a completion nodal dissection, which means we remove all of the lymph nodes in that particular basin, is because if there is documented gross disease in one lymph node, then there is, 1 centimeter, 2 centimeters in size, then the probability of having microscopic disease in the lymph nodes in that basin is very high. And for that reason, we basically remove all of the lymph nodes, even in the absence of imaging evidence that it's there. And that's often the case. I would say more often than not, we will find additional disease in those lymph nodes. It's a very, I think, nuanced discussion with the patient. Obviously, it's not a risk-free surgery. However, the risk of lymphedema increases with the size of the lymph node and the disease burden within the basin. And so actually sort of waiting to see, if these tumors get bigger or more tumors recur can potentially make kicking surgery down the road a little bit more high risk for that complication. But again, I usually have a discussion with the patient, and then we have what's going to be the best decision for them. But in most cases, actually, lymphedema is quite manageable, and I do a lot of these operations. And clinically relevant lymphedema is really, I think, what everybody worries about, but it's not as prevalent as patients think. So I have them meet with occupational therapists and physical therapists before we get measurements. You get fitted for garments, and there are definitely ways to manipulate the swelling and that ultimately will happen from surgery. But we try to minimize it so that it doesn't change your lifestyle or affect your day-to-day.
Yeah, thank you. It sounds like you take a very proactive and holistic approach. And a follow-up question to that. So regarding preventative removal of abdominal and pelvis lymph nodes that was not done in the initial surgery, what criteria are there to remove it or not, and what side effects might this cause?
This is such a critical point, and it's one of the things we alluded to the fact that, especially in low-grade disease, well-differentiated low-grade disease, that is appropriately surgically resected without evidence of metastasis, we can really achieve what would be equivalent of a cure, in that people die from other causes. And so that first operation is really critical. And so I always really try to remind people of that your first operation, if you know that you have a neuroendocrine tumor, should be done by someone who takes care of this disease all the time. But in the setting of lymph nodes left behind, I see this all the time, and I do usually recommend additional surgery for lots of reasons. There's almost always disease left behind at the time that I see patients, whether we capture that on cross-sectional imaging, on CT scan, or on PET dotatate. Especially for small bowel carcinoids, the lymph node drainage from these carcinoid tumors is quite extensive. And it helps us to not only treat their disease surgically, but also prognosticate. And it also has implications for adjuvant therapy. So I do think that if a regional lymph node has not been lymphadenectomy has not been performed, I typically recommend it up front. And more often than not, I find additional disease at the time of surgery.
Thank you for that. And one last surgery question is, what's the latest news for liver transplant for NET patients with localized liver mets?
So this is a big topic of a lot of debate. So there's been some recent changes in the allocation of deceased donor liver transplants. And previously we were very tied to sort of geographic location and availability. And so in some cities, you were more likely to get a liver transplant, and in other cities, you were less likely to get a liver transplant, regardless of how sick you were, based on sort of the pool of available organs in that particular city or area. To sort of try to ameliorate that and make that more even or fair, they've changed the way that we regionalize how organs are distributed. And so what that's done is it has increased availability of organs to patients that are sicker and have higher MELDs. And from the standpoint of neuroendocrine tumor, it is a disadvantage because we don't necessarily get a lot of the bonus points for cirrhosis or a HCC that would sort of put you at the top of the list. So I think this has really re-energized the conversation around living-related donors for liver transplantation. And so I do think that there are some centers that are still interested in transplanting patients with neuroendocrine tumors that are isolated to the liver. But mostly, I think this is going to be in the context moving forward for living-related donors.
Thank you for that. And briefly, I'm going to try to take a couple of treatment-related questions. So, Dr. Coons, this is a big question. What are treatment options existing or upcoming for individuals who do not have somatostatin receptors?
That is a very hot topic right now, and I think one that the NET community is really actively trying to investigate. So there are some agents that can upregulate or increase somatostatin receptors being expressed on the surface of cells. Those are being evaluated in very early phase trials. I'll point to Dr. Suarez, who's actually personally doing some of that work. So that's one. And I think then really thinking of agents outside peptide receptor radiotherapy. So I think we're eager to see if there are other biologic or targeted therapies, or are there, I think immunotherapy we've been talking about for years for NETs, and single agents don't seem to work, but our combination therapies. So I think, yes, in the last 3 years, the peptide receptor radiotherapy has really been the hot news, but we also don't want people without somatostatin receptor expression, or even people who progress on PRRT. We want those patients to feel like, yes, the research community is actively thinking about that.
Dr. Coons, here's another really important question. This was upvoted as well, so I want to get to it. In treating pancreatic NETs that have metastasized to the liver, et cetera, are therapies such as CAPTEM and PRRT used more than once when disease progresses again?
So that's a question that's sort of broadly an oncology principle. Usually, if somebody progresses on a given therapy, we usually set it aside and generally do not return to it because of concerns that those cancer cells are resistant. So I think I might use as an example PRRT. So I think This is a slightly different setting than your specific question, but for patients who've had the standard 4 doses and then have a long period of disease benefit or duration from that PRT, we can sometimes consider retreatment and using it. But that's really only because we think patients had benefit the first time around and didn't have resistance to it. So overcoming resistance to certain treatments is also an active area of research broadly in oncology, but to specific agents and figuring out why those resistance mechanisms develop and how can we overcome them.
Thank you for that. And Dr. Hafthanarsson, I'll address this question to you. Is there new treatments for DIPNEC? And please expand a little bit on this.
So not necessarily new treatments. The question is, why do you treat DIPNEC? So a lot of DIPNECs don't have to be treated at all. So these are essentially tiny little clusters of neuroendocrine tumors, and it can occasionally over time evolve into a more aggressive invasive neuroendocrine tumors, but a lot of times actually it doesn't, even over the course of many, many years. So the reasons to treat DIPNEC are predominantly symptoms, shortness of breath, wheezing, like asthma symptoms, and somatostatin analogs seem to have some activity there. We collaborated with Moffitt and with a center in Israel looking at this, and we found that there is definitely, it seems like somatostatin analogs may work. Other treatments such as PRT, everolimus, and others may be considered for really progressive disease, but the first question you need to ask, do you have to treat it?
Thank you so much. And thank you for this first group for all of your time and energy and all your dedication and hard work. And now I'm going to hand it off to Josh, who will moderate the second part of our Q&A.
All right. Well, it's great to see everyone here. And many of us have worked together in many of these settings and these conferences. So it's a pleasure to have all of you here. I'll get right to it. As we look towards the second QA panel with Dr. Netting, Dr. Del Rivero, Dr. Hope, and hopefully Dr. Druma when she's able to join us. There's lots of questions, and I'll start out with Drs. Hope and Netting. I know, Dr. Netting, in your conversation, in your particular talk, you talked about following PRT with seer spheres and the study that you did as well. And one of the things that of question or concern is for those who had seer spheres prior to PRT, you kind of mentioned a little bit about the Penn study, but do the two of you want to comment about how you view patients who've had seer spheres and are looking for PRT?
So I think these patients need to be discussed in a multidisciplinary setting. There's really 2 different products, and I wouldn't consider resin microspheres and glass microspheres the same product. Typically, an infusion of glass microspheres tends to be about 2 to 3 times more radioactive than resin microspheres. So you really have to look at all of these things in combination. Dr. Sulin's study showed that patients who were heavily pretreated with liver-directed therapy that then underwent PRRT did have a higher complication rate than patients who historically did not have much liver-directed therapy. I don't have a great answer for you. I think it needs to be discussed with all the players who are treating these patients at the same time.
Yeah, I think that's exactly right. The only thing I would add is one thing I think patients oftentimes don't think about is the size and distribution of their tumors, which is really why you do need that multidisciplinary discussion, which is if you have like one big lesion in one area, hit that with radioembolization. If you have diffuse tumors, the impact on the background liver parenchyma is different based on the geometry and the location of your tumors. And so there's no right answer in this discussion. And actually, sometimes we have done Y90 prior to PRT purposefully to debulk localized large tumors so that the PRT will go to the residual. Whereas, so you really need to take into account the geometry, the location, and you really need your IR physician and nuclear medicine physician to talk to each other and think about what's the best for that individual patient. And there's really no right answer.
Thank you for that as well. And the next question coming up is about Y90 liver embolization. is it superior to bland embolization? Is it worth the potential additional damage? Although I'm not sure there's any potential damage to healthy liver tissue in comparison. So, and I know Dr. Netting, you touched on that a little bit. Do you just want to answer this quickly with just a follow-on?
Sure. So I would say that there has been a lot of discussion recently about RILD, or radiation-induced liver disease, that happens from Y90. It definitely can happen. It's probably more common with a glass microsphere versus a resin microsphere. That being said, it is relatively uncommon. And we tend to use radioembolization more segmentally or lobar. 10 years ago, we used to treat lots of whole livers with Y90. Now we reserve it more for focal or segmental infusions of tumors that may be difficult to access surgically, such as those underneath the diaphragm or in the center of the liver.
But interestingly enough, Dr. Hope, we've had a lot of things recently, and this is onto antioxidants, and we'll see if Dr. Duma comes back in, but doing antioxidants while you're doing PRT or during therapy. And so do you have any recommendations, or what do you tell people about integrative oncology, using antioxidants or other supplements prior to PRT?
I think what is very important is to meet with the pharmacist and go over every medication, and all depends on the treatment the patient is in. Most of the data is extrapolated from other more common tumors, like breast cancer, in which antioxidants are not recommended when you're in chemotherapy. But there's a lot of medications or a lot of complementary medicine that are not controlled at all. And I have lost patients to the side effects of these drugs, for example, cheese or other supplements. So I think having an open conversation with your oncologist is important. If your oncologist doesn't feel comfortable, the pharmacist can be a very good point of contact. And if that pharmacist doesn't feel comfortable, many institutions have a complementary integrative group that we go over the supplements. Because currently, I think in the last few years, we have seen more and more supplements. And many of them are unknown how they will interact with therapy. And I have seen supplements that make the symptoms worse, particularly now, they can make it significantly worse.
Dr. Hope, what do you do with patients who are coming up to you about and asking those types of questions?
Yeah, I think Dr. Duma hit on a lot of the points there. You know, in the end, we don't know most of the interactions here. I mean, I deal primarily obviously with PRRT, and we don't know if it helps or hurts any, how they interact with supplements. I think the symptoms is something that patients themselves, they learn that as they take their supplements, and they can, see how their symptoms change. We have had patients who take supplements and have negative effects from them because they take so much of them, but that would be true in any setting and not specific to PRRT. And I think you asked specifically about vitamin D, which is slightly different. I don't think of that in the same setting as a supplement, in the sense of like vitamin D can be potentially an anti-cancer therapeutic, and probably does interact with radiation therapy in some way, although we haven't proven that in any prospective study. So there are things like that are being studied in colon cancer and other cancers that may potentiate a therapy, but I would not start using that now unless we have trial data to support it.
So, Dr. Hope, there's a few questions on imaging, specifically, and I'll try to bundle them up here a little bit, but relative merits of copper-64 dotatate versus other dotatate scans as well. Do we always need PET scans? PET scans versus CTs? Often we hear PET scan is the gold standard. And when are the times that you don't use a DOTA PET scan?
Yeah, so the first one, neither of those questions are particularly easy, but copper versus gallium. So copper is a little more technically challenging because it has a lower amount of decays. The positron that is emitted, there's fewer of them, so you need to scan for longer to get an equal image. You can make them the same by changing your acquisition protocol and optimizing it for your specific scanner. In general, the difference, even if you didn't image for much longer, the diagnostic differences between the two compounds would be very, very limited in terms of the impact on the actual management of the patient, right? If you have a little noisier picture, you're not going to miss the majority of the disease. It might be harder to see small, very sub-centimeter sites disease, which is not really going to change the way a patient's managed. So in general, I think of them as equivalent. We use them both at our institution. We've been doing more copper recently for various reasons, both distribution reasons and reimbursement reasons. The second part of your question about conventional imaging versus DOTA, I generally would not recommend DOTA for routine surveillance of patients over time. I think you really want to see whether or not stuff is anatomically changing in size to see if patients are progressing. Changes in uptake on a dotatate is not indicative of progression in and of itself. It's really either seeing new lesions or the change in size of lesions. And then I think, Dr. Nutting might be able to speak to this, but a lot of people need conventional imaging to plan their therapies, right? A surgeon or an interventional radiologist, you want to know if that lesion's arterially enhancing, you want to see the anatomy of the arteries, et cetera. So there's significant value in conventional imaging, and that should still be the workhorse of the way that we follow patients over time.
I agree with Dr. Hope. I think that we get a lot of anatomic information from contrast-enhanced CTs as well as MRIs. DOTA scans are great because it's easy to see disease, but some of these other scans are helpful to determine increasing size.
Dr. Del Rivera, just going back, I know you're kind of here on symptom management and in your role as an endocrinologist, and it's so good to see you in this flat earth that we have here. So do NETs produce hormones which affect other diseases such as endometriosis, or what other impacts does this have on us?
Thank you so much, Josh, for the question. And as we all discussed earlier, and something that we need to differentiate is between the tumors that produces hormones versus a tumor that do not produce hormones. And in terms of the tumors that produces hormones, whether they are from the small bowel producing serotonin, that's what basically causes carcinoid syndrome, or because it's the pancreas, neuroendocrine tumors, because the pancreas is a very juicy organ that produces a lot of hormones, produces somatostatin, glucagon, insulin, pancreatic polypeptide. So there is a lot of hormones that is produced by the pancreas. However, based on what the neuroendocrine tumor is that produce a specific hormone, they have specific symptoms that don't necessarily correlate with other diseases within the organ. It has a series of symptoms, like, for example, pancreatic neuroendocrine tumors producing insulin. So we know the symptoms is low blood glucose, but that doesn't mean that it could cause other secondary cancers, or it can cause any endometriosis, like you discussed earlier. Now, in the sense of Cushing's, for example, that's another hormone. Bronchial neuroendocrine tumors, in rare cases, they may produce a hormone called cortisol. It's a hormone that may stimulate the production of cortisol, and that excess of cortisol has a series of symptoms. It can cause obesity, the red face, what we call the buffalo hump. That's kind of like one of the characteristics of the excess of cortisol. It can affect also the bones, making your bone weak. It can also cause hypertension. So those are kind of like the effects of the hormones in a specific organ of function, but doesn't necessarily cause any other diseases that are not related to the neuroendocrine tumor. I don't know if that answers the question.
It does greatly, and I kind of a follow up to that in a sense here is we're taking SSAs in the earlier session we talk about somatostatin analogs all the time, and much like when we're under any other therapy, are there any diet or treatments or other supplements that might help the cramping and bloating or the gurgling that comes with the GI tract after taking a somatostatin analog? And I'll open that up a little bit. I'll have you talk about SSAs to start out with, but certainly other things, thinking about diets while going through other therapies as well.
Okay, great. Well, thank you so much. That's also a good question. But first, I think the first thing that I would like to describe is what SSAs are doing, somatostatin and lanreotide. So one of the things that these medications are doing is inhibit the hormone in the pancreas. So every time that we think about somatostatin agonist, is an inhibitory type of drug that inhibit the function of the hormones in the pancreas. That's the reason why whenever we have a pancreas neuroendocrine tumor, so we have a functional neuroendocrine tumors, somatostatin agonist has two functions. One is to control the excess of hormones or the symptoms related to the excess of hormones. And number two, it has an anti-tumor effect to slow down the growth of the tumor. Now, in the sense of having these inhibitory functions or inhibit these hormones in the pancreas, one thing that they're doing is that also inhibit the function of some pancreatic enzymes. So sometimes there is some difficulty by breaking down fats, breaking down sugars, breaking down also some starches. And that's basically what it causes the symptoms of bloating and so forth. Now, usually it occurs a few days after the implementation of the injection of the SSA. And over time, it tends to get better. But in the time that these symptoms are, these medications are causing these symptoms, sometimes that could help, for example, is to minimize the amount of fat and the amount of sugar as well, because as we say, this medication can sometimes slow down the breakdown of the fats and sugars, and we're able to minimize the amount of these sugars or fats that we're ingesting, maybe having small meals throughout the day. Sometimes that can definitely help to some of the symptoms. Now, there are some other broccoli, for example, this cruciferous kind of like vegetable. So that can also cause bloat, and maybe minimizing that as well can help in those situations. But yes.
So Dr. Hope, I'm going to throw this at you for a second. I often have patients who have platelets that drop in, and either think or want to know if there's some type of dietary things that they can do to help up their platelets, or how do you tell patients to manage their diet, or do you in concerns with their blood work? Because I know this comes up a lot in patient land.
Yeah, I don't know how I got into being a dietary representative on this show here, but in general, the way I think about it is when we give, in the setting of PRRT, when you have low platelets, red blood cells, and white blood cells, there's a cause for that. It's the radiation entry to the bone marrow. And it's not exactly something that's going to be fixed by a dietary change or a supplement. So I obviously, I like to stay in my lane, and my lane is a nuclear medicine physician. So we have a very strong nutrition service that we send patients to have these discussions. But in general, I don't make strong recommendations. Really, it's a tincture of time, right? PRT, most of the low counts is due to the radiation effect, and they'll recover over a period of time. And really, it's waiting for your marrow to recover from the transient injury from the radiation.
Yeah.
I'm going to stick on the somatostatin analog world here. When is the appropriate time to have imaging vis-a-vis and therapy vis-a-vis your somatostatin analog injection?
That is a great question. I think that's changing. Our belief in that is changing over time. So I'd say 5 years ago, we were all doing it days before their next injection, right? We were very strict about it. And then there was a paper that came out 2 years ago that showed with lanreotide, there's very little impact on the uptake seen on somatostatin receptor PET. And then there was a recent article actually a year ago now with sandostatin that showed a similar lack of impact on your SUVs, the uptake on the PET imaging. And actually, I think I'm becoming much less stringent on that criteria. So with lanreotide, we still schedule our treatments because that you have a little more control over before the next dose. But in terms of imaging with lanreotide, I'm caring less. I don't think it makes really any difference. With sandostatin, I've had a patient where they were on very 120 milligrams of sando, and that did actually impact. You could clearly see it sort of attenuating the uptake on the dotatate PET. But in general, in patients with normal doses, I don't think it makes any difference in terms of timing. So but that's changing. My mind on that's changing over time.
Certainly, I think it is an evolving science because we didn't know a lot in the beginning, and we were just certainly taking guesses here. And it's really great that we're doing this with more information now. Dr. Netting, do you think there'll be a time when ablation for small p-nets will be a common procedure?
I would assume that's discussing liver-directed therapy.
Yeah.
And as far as small goes, Dr. Thor had mentioned earlier, is it something that you need to treat? In general, we tend to treat tumors that are 3 centimeters in size and 3 or less in number with needle-based therapies, such as ablation. In my practice, I don't see very many 1 centimeter tumors that are isolated. It tends to be more of a diffuse disease spread throughout the liver, and that tends to be treated with regional liver therapy.
Back to you, Dr. Hope. This is kind of the PRT questions in a couple different ways. One, in NETTER-1, did you see any complete responders, or have you seen complete responders as part of those who are undergoing Lutathera?
We have not seen any complete responders in the patients we treated with Lutathera to date. Now, I will say the definition of a CR in a setting of NETTER-1 versus clinical practice is different. What I mean by that is now that we have dotatate PET compared to conventional imaging, it's much, much harder to be a CR. And I think my take-home point would be PRT does not cure patients, right? And actually no therapy we do cures. And I'm not aware of, and maybe Josh, you're aware of one ever, but I'm not aware of any patient ever who has had, quote, a cure from PRT. So CR just means we knock that disease down so much, and it's hard to see on conventional imaging, but it's still there. And I think there's maybe a misunderstanding of what CR means maybe in the patient community, that means that they have no disease, and that is not true.
I'm going to follow that up, and I'm going to get back to your point there in a second. But the other follow-up to that is PRT effective when you have large tumors greater than 5 centimeters? One of the questions is this an effective therapy when you do have large tumors? And I would assume also a large liver load of tumors as well.
That's a great question. So so the larger your tumor is, the less benefit there is from therapy. And that's probably true across all therapies, right? Bulkier tumor, higher volume tumor does less well with any type of therapy just because it's a worse prognostic finding for a patient. PRT in the NET, they retrospectively looked at patients in NETTER-1 and showed that the patients with larger tumors did less well, but there was still a benefit over Sandostatin, right? You still had the clinical benefit. So it's not that you shouldn't treat patients with tumors like that. And we have had patients clearly who've clinically benefited and had prolonged progression, radiograph progression-free survival from it. So I think it still should be used. Now, I think maybe what this question might be trying to get to is when should you use PRT? And it's a volume of disease, and we don't really know the answer to that. So I think there's clearly there's too low volume disease to treat, right? I don't know how you define that. And then, you don't want to wait till you get too big of a volume disease because the benefit, you're spreading out your dose over more tumor and there's less of a benefit. So there's this sweet spot. And we haven't defined that sweet spot, but I believe that there's some sweet spot that exists where you want to treat patients with PRRT that has sort of moderate volume disease where it's going to be most effective, right? You want to use that drug in the window where it's most effective.
So the last question is actually to me, but I'm going to turn it around and make it to all of you, just because I can. So we've just gone through a conference where we've had 10 wonderful doctors from really around the country, literally everywhere around the country. We're not all able to afford to go see you all. The question really was, are there any sponsorship or grants to have us see you wherever you are? But how are you dealing with seeing patients from around the country? Obviously, Dr. Netting, to actually do any liver-directed therapy, you actually have to have them physically in Denver. Hard to do that remotely yet. We'll get to that technology soon, I hope. How are you seeing patients around the country? What do you do for people who want to either have a second opinion with you and or deal with this kind of travel in this new flat Earth?
Thank you so much, Josh. I appreciate the question. So as we know, NIH is a research institution, and every patient that we see at the NIH has to be enrolled under a specific protocol, whether it's a treatment protocol or whether it's a natural history study. At the NIH, we have a natural history study for neuroendocrine tumors. I am the PI of that study, and it's a longitudinal study, meaning that I'm allowed to follow patients long term. On that study, we have two cohorts of patients. We have a field cohort and we have a clinical cohort. Clinical cohort are for patients that are able to come to the NIH. Field cohort are patients that could be from anywhere all over the world. And the idea is that we collect all the information, we collect all the clinical information, collect tumor, collect any radiology. And what we do is that we present that on our tumor board. We have a tumor board every Thursday. And then we have our own clinical group, which we help make the decisions about the possible recommendations for the patients. We then give the recommendations back to the patient. And of course, we always say we haven't seen you in person, but this is based on the scans, based on the labs, based on what we review. This is our recommendations. And we're always happy to talk to any of the providers outside of the NIH. So that's an easy way for patients. So because it's under a research study, is without cost, but at the same time, we don't necessarily see the patients in person. So that's one thing. It's a research study, so the patient needs to be eligible for this study as well in order for us to evaluate any neuroendocrine tumor.
So Dr. Netting, are you seeing people remotely before they come to Denver, or how are you doing your work?
Yeah, thanks, Josh. I think one thing that COVID has done is really forced the evolution of telemedicine. And so I'll see patients remotely. We can also share images through different platforms such as nucleus.io. And we could come up with a treatment plan for these patients before they ever come see us in person. So it's very common for us to discuss them in a multidisciplinary fashion, get insurance authorization so that when they do come to Denver, we're ready to treat them.
And Dr. Hope, I know you certainly see patients remotely, whether they're inside of your Northern California area or from around the country. How does that work?
Like this? No.
It looks pretty much like this.
No, I mean, this is what I love about the neuroendocrine tumor community from the patient side, is that patients really do, and they've been doing this well before, COVID. They see physicians, get second opinions. We all share each other's patients, and COVID just made it easier, right? And you do it over Zoom now, and that's sort of acceptable, right? The first time, it used to be that the first time you saw a patient was always in person. And that was sort of like the rule of thumb. And that's actually just gone out the window. Which is really nice, which makes it much easier to see patients love getting second opinions, and they should, because it helps you feel more confident in the decision that you end up making. And I think that's really important. So COVID's done a really great job sort of breaking down these barriers that have historically been in medicine about how you had to see patients in person to really give access to patients to get second opinions around the country.
So I want to thank you really all for your time. It's such a great pleasure to see you here, even though we're all flat, but we're used to seeing each other this way now, and hopefully we see each other in person soon. I want to thank everyone for attending today. And I know we've had probably 75 questions, and we probably made it through 45 or 50 questions in this hour and 5 minutes. So sorry if we couldn't get to all of yours, but LACNETS, as well as many of the organizations around the country, run webinars almost every week now, if not weekly. So we're sure you can get your questions answered somewhere. And with that, I'm going to say goodbye and turn it back over to our producer at the studio.